Moi Teaching and Referral Hospital is one of the pioneer hospitals in Kenya, having been founded in 1917 as a cottage hospital with a bed capacity of 60. It was to cater for the health needs of Africans in the Rift Valley. From the grass-thatched staff quarters in 1952 to the construction of Nyayo wards in 1986, the hospital has witnessed tremendous transformation. But it was the establishment of Moi University in 1984 and the subsequent establishment of the Faculty of Health Sciences that marked a turning point for the institution, leading to its current state of progress. The hospital currently prides itself with over 1,000 bed capacity, besides having diagnostic and clinical equipment.
We have slightly about 1,000 beds for admission. We also have an emergency department, an outpatient department. We have a cancer unit or a cancer center, the Chandaria Cancer and Chronic Disease Center. We also have the Children Hospital, which is part of the outpatient, the Shoe for Africa Children Hospital. And we have the private wings, Private Wing 1, which is amenity, and Private Wing 2, which is memorial. So all these, when you add up, they come up to about 1,000 beds.
The hospital receives over 1,000 patients daily in its outpatient and emergency wing. It has a catchment area with a population of about 20 million people.
On any given day, we see a total of 1,000 patients, both in the outpatient and emergency department combined, with different types of conditions and referred from the whole region that we serve. And as you know, we serve all the way from Nakuru to the eastern part of Uganda, to South Sudan, and sometimes also to Rwanda, and most of the western part of Kenya that comprises of Rift Valley, of the former Rift Valley, Western and Nyanza provinces. So other than the outpatient attendances that I've just mentioned is about 1,000. On any given day, we have about 1,100 patients admitted to the various wards in the hospital. So given that the beds are about 1,000, that gives you a bed occupancy of about 110% on any given day, meaning that the patients exceed the number of beds, and therefore they have to share beds because we cannot turn away any patients. And part of the challenge there has to do with the fact that most of the county hospitals that we serve, and there are about 22 counties that we serve, they do not have adequate capacity in terms of their hospital bed space, and also the number of specialized personnel, particularly the doctors and the nurses and the biomedical engineers. So they end up referring most of the patients with complications to Moi Teaching and Referral Hospital, hence putting a strain on Moi Teaching and Referral Hospital. Despite that challenge, what we do is we do our best to serve everybody by making sure that our services are not only efficient but effective and of the highest quality also. So we make sure that patients do not delay to get the services. They do not delay to undergo the necessary investigations, which may be laboratory, radiological. And as soon as they are investigated, if they require, for example, to be operated, they are operated immediately. And if they require to be given specialized medications, they are given those medications. If they require to be dialyzed, they are dialyzed immediately, and so on and so forth. So our way of managing the capacity challenge, the high demand and low capacity in the region, is by making sure that we are efficient, and therefore discharging the patients as soon as they get well, to allow or to give room for the other patients also to come and be served. So with that kind of background, then I would also want to add that one of the other issues that we face on a day-to-day basis is a challenge with healthcare financing, whereby most of the patients that we serve are not able to pay their bills and end up being credited or being waived altogether because they are not able to pay the bills. And then secondly, a good number of them do not have any mechanism of healthcare financing, so they pay out of pocket, relying on their own savings because they lack insurance, medical insurance cover. So what we have done working with NHIF is to go around, starting from the county that hosts MTRH, and ensure that people, even before they get to the hospital, they are registered to NHIF. And I want to say that this has been very successful. We have gone to every corner of this county, working with NHIF and the county government to ensure that everybody is registered with NHIF. So we have MOUs that cover the kind of services that they can refer patients for here in MTRH, and also how we can refer back patients from MTRH to those county hospitals, because there is also something called a downward referral. Then they will be doing upward referral as we do downward referral. So that that's another way of managing capacity challenges. We operate for them and send the patients back to recuperate. Now, for those that where they have equipment, the necessary equipment, what we do is that we will be sending our doctors, particularly surgeons, gynecologists, pediatricians, to go and work with those county hospitals so that they can manage the patients from there instead of the patients being referred upward to MTRH. They can be taken care of also at the county level. So that is kind of referring the technology itself rather than referring the patients. You are aware also that just for the first time in the history of this country, the issue about teleradiology, the technology of teleradiology now is alive with us. And His Excellency the President had, with the Governor of Kericho and the medical radiographers in Kitui, in Kericho, and MTRH had a conference, a teleconference, where they discussed about a patient who was being investigated at Kericho County Hospital. So that's another way that we are going to manage issues of referral. Instead of a patient being sent all the way from Kericho for an X-ray or a CT scan here, it is now possible that the X-ray alone is sent here, the X-ray film is sent here to Moi Teaching and Referral Hospital. We interpret and send the results to Kericho or to Kitui or to Mwingi and anywhere else in the country who are connected in the system. So that, in a nutshell, is what we are doing. And I would like then to go briefly to the kind of equipment that we have or that we need for a level 6 specialized teaching and referral hospital. And as you know, our vision as Moi Teaching and Referral Hospital is to be a world-class teaching and referral hospital. And certainly, I want to assure you, we are walking that path to ensure that we have what it takes to be a world-class teaching and referral hospital. And even without just narrowing down on the equipment alone, for us to reach there, we also need to have the right human resources for health, in the right skills mix and training and capacity building. Then we need to have the necessary equipment, and then we need to have adequate bed space, and we need to have all that it takes, including even support services like transport, that's ambulances, and having also the necessary, power, electric power supply to the institution, including good backup, and many other requirements that make a level 6 hospital.
In a bid to enhance its efficiency and effectively discharge its mandate, the hospital has entered into partnership with like-minded stakeholders. One such partner is Academic Model Providing Access to Healthcare, popularly known as AMPATH. The AMPATH Center is connected to MTRH and the staff work closely together.
So this is the Chandaria Cancer and Chronic Diseases Center. As you can see, it is a very beautiful complex, and it is here where cancer and all the chronic diseases are prevented and treated. Yeah, and as you know, we are now shifting more from infections to chronic diseases, the so-called lifestyle diseases, and cancer is one of them. So everybody coming to the hospital with cancer, with hypertension, heart failure, respiratory disorders is treated here. And inside here, you will get sufficient equipment for both diagnostic and curative purposes. Not necessarily housed here, but the decisions on what happens to all those patients is made here. Yeah. The main activities that go on here is dispensing and administration of drugs. There's a section behind there where we are going to get radiation equipment in the near future. We are working on that. And then other things like mammography, which we use to screen for breast cancer, are available in the X-ray unit of the hospital. And then, of course, when you have cancer, you also undergo surgery, and that is available in the main operating theaters, the Majaliwa theaters. Yeah. But if you come here, the entire ground floor is for clinical services, and then we have a floor just purely dedicated to research. So we do a lot of research here, and in very many fields. Research is open, it's not restricted to chronic diseases alone, but within the medical field, research that is useful to the people.
I would like to let you know also that when you're thinking about medical equipment, you also have to think about the health workers who will operate those equipment. And in fact, and also when you're thinking of constructing a new hospital, you must fit in the equipment at the design stage, not later on. So meaning that you should know where the MRI is going to be, the CT scan is going to be, dialysis equipment, and so on and so forth, at the very, very, beginning at the design stage. Because you don't want to come later on and start demolishing walls to allow an equipment to fit in a particular area of the hospital. And that's exactly how we've been doing it as Moi Teaching and Referral Hospital. We, at the design stage, ensure that equipment is well thought about. We also ensure that if it is going to take 6 years, for example, to train an oncologist, we send the doctors and the nurses early for the training, even way before we receive the equipment. And that is the kind of planning that we do, and which I would like to encourage even the county hospitals also to always think ahead of time and plan for all this. We have modern X-rays, courtesy of the MES program of the government. We also have, and the X-rays include a mobile X-ray. There are the fixed X-rays and a mobile X-ray. We also have a mammogram, a new mammogram. So we have 2 mammograms now, over and above the one that we had. We have a new mammogram, again courtesy of the MES. Then we also received new dialysis equipment from the MES, 5 of them. Then plus the ones that we had, we have about 15 dialysis equipment now. And specifically about dialysis, I would like to let you know that we are now partitioning a new dialysis center at the Chandaria Cancer and Chronic Disease Center on the 1st floor. This center will have a capacity for 30 hemodialysis units, making it then the largest hemodialysis center in the East and Central Africa region. And shortly, when it is commissioned, perhaps in the next 1 month or less, we will be having 20 dialysis units ready. Again, courtesy of the government, the MES equipment supply system. And therefore, that will definitely go a long way in alleviating the challenges that we've been facing with hemodialysis, because the number of patients that we dialyze has really gone up more than any other time. And we are dialyzing like close to 300 patients in a month. So we need to prepare. And as you know, the non-communicable diseases are on the rise, including kidney failure, for various reasons, including lifestyle challenges and dietary habits and sedentary living styles, and everybody just being in a car instead of walking to work, for example. So all those challenges are catching up with us, and therefore we need adequate equipment to serve the people who would have been affected one way or the other. I would also like to say that over and above that, we are expanding our ICU, intensive care unit, to 22 units from the current 6 units, so that no patient who needs ICU care or high dependency care will have to go to any other place, or will have to struggle. And we will also, take care of the Kenyans who are unable to pay, and particularly by ensuring that every Kenyan, every family that we serve has registered with NHIF or any other relevant insurance. So the works are going to commence in a week, and within another 2-3 months, we will have a fully equipped 22-bed ICU unit. We are also expanding the neurosurgery ward, having a new neurosurgery ward that will have enough capacity of over 20 patients, including a theater and an ICU for neurosurgery, because you realize that there are many trauma cases that we handle, particularly as a result of border accidents and other road traffic accidents. And we therefore have to be proactive by ensuring that we have adequate ward space, theater space, and that these patients, as soon as they arrive and they are stable enough to go to theater, they are operated without any delays. And you realize that for most neurosurgical operations, we also need to have ICU backup, because these patients tend to be very sick and require necessary ICU support. So it has been a challenge for the neurosurgeons to operate when the ICU space is inadequate, because they have then to wait, and we always have to struggle to get a bed among the 6 beds which are available. So that is being done, and it will be equipped. The 22 units will be equipped, each one with its own monitor, its own bed, and its own ventilator. A fully equipped ICU. As you know, also we have the Children's Hospital, and it has theater, actually 2 operating tables, plus an ICU and an HDU. The ICU is about 6 beds, and the HDU is about 6 beds. So I would like to say that also in the new financial year, all these are going to be equipped fully to take care of any children who might require intensive care support or high dependency support services. So other than that, then we come to cancer, where we, as you know, it's in the Chandaria, cancer and chronic disease. Our oncology department is there, and we have already patients are being treated there with drugs, what we call chemotherapy. They are also being screened, and they are also being done surgery for cancer. What is remaining is only radiation treatment using radiotherapy equipment. And I would like to tell you again that the government, through the Ministry of Health, is in the process of acquiring for us at least 1 equipment, and in fact might be 2, but at least 1, that is a linear accelerator for radiation treatment. And there might also be a new Cobalt 60 to help with the very advanced types of cancers, in treatment of the very advanced types of cancers. So we have already 1 bunker that is ready for this equipment, but there is a provision for another 3, which now we will start working to increase to another 3, making it a total of 4. I would also like to tell you about the new laundry and a new kitchen. These are being done already. The designs are ready, and the work will also be commenced soon, so that in the course of the new financial year 2016-17, we'll have a modern kitchen and a modern laundry, because these support services are so critical in the efficient and effective running of hospital services. We are also going to give a facelift to the hospital. Things like curtains, beds will be done afresh to modernize MTRH to what it is supposed to be. The Children's Hospital, again, there is a kitchen that is coming up that is dedicated for the children. It's 80% done. In another 1 month will be complete. So children catering services will be taken care of from the Children's Hospital, whereas the main kitchen will take care of the rest of the hospital. For the farewell home, otherwise called the mortuary also, works are already going on at 70% for creation of an embalming room. As you know, are the technicians who work in the farewell homes. So the first intake we will be able to take in September, at least a class of about 10 technicians for training to serve the whole country. And therefore, that is why we had to do an embalming room, which is almost complete. The training school, and our training school is very competitive. We focus mainly on courses that are subspecializations, including, for example, cancer trainings for clinical officers and nurses, renal ICU training for nurses, theater training for nurses, Now the morticians course, which I've just mentioned. We also train anesthetic assistants. Again, the only course in the whole of this Eastern Central African region that caters for the technicians in theater who will be assisting anesthesiologists. There are those doctors called anesthesiologists who take care of a patient when undergoing surgery, but they can't work alone without the technicians. So for the first time, we are going to have formally trained technicians called anesthetic assistants to offer that kind of support to the anesthesiologists. And again, the Ministry of Health has already given us the necessary approval to commence this course come September. So what we are doing is to expand also the training school, and the works will begin in a week also to have another 4 new classes to take care of the increased numbers of students. And like I said, we are not competing with the colleges that provide basic training. We are only focusing on the higher national diplomas and postgraduate diplomas in specialized areas. Apart from the others that I mentioned, we also have a higher national diploma for pharmacists in what we call clinical pharmacy. Again, the only kind of its course in the region. And the idea of having this course is so that pharmacists who are also doctors can work not only at the dispensing level, but they should be able to work at the level of the ward, at the level of the clinic, by actually taking care of patients as part of the team. And that will increase, the quality of care. It will minimize on drug errors. It will minimize on unnecessary drug interactions to the patients, and therefore make their treatment experience to be more safe and more predictable. So those are some of the things that we've done, which we believe, and again, in response to market needs and market trends that are required at a level 6 hospital like ourselves. Needless to say that other than hemodialysis for the kidneys, this center now does regular kidney transplants, putting us at a level, equivalent to, for example, maybe in this country, the other hospitals that can do kidney transplant is Kenyatta National Hospital, Aga Khan University Hospital. Perhaps only those 3 really are the only ones that can do kidney transplants. Now, another unique service that is coming up soon, and we are at advanced levels of planning and preparing for the same, is open heart surgeries. If you see the kind of heart diseases we see in this region, it mainly still afflicts the children and the young adults, and it's in the form of rheumatic heart disease, which eventually, normally it comes from throat infection going down and damaging the heart valves. And eventually the heart valves are damaged, causing the heart not to function well and to fail. So these children have had to be referred to Nairobi, specifically to Mater Hospital, for open heart surgery, valve repairs and replacements, or to Tenwek Mission Hospital in Bomet. But we've said really, because the number of patients is so large here, we need to have this service in Moi Teaching and Referral Hospital. So working in a partnership with Medtronics, which is a US cardiac equipment company, it manufactures and supplies cardiac equipment. That company is donating a new open heart surgery equipment, which is called a heart-lung machine, plus its accompaniments. It's also helping in training our cardiothoracic surgeons and nurses and technicians, anesthetic technicians, who are called perfusionists, and also biomedical technicians who will be taking care of the equipment. And working also for the same, working in a partnership with Indiana University, who will be, helping in training our surgeons, and University of Toronto, Indiana University in US, and University of Toronto in Canada, who will be helping mainly with the with the medical care of the heart. We are able to start this surgery in the new year. In 2017, we should be able to do open heart surgeries here, and therefore cut on the number of patients who have had to go abroad, particularly to India, for this type of surgery. So that, in fact, the equipment is already on the way. It's been shipped, and our doctors and nurses and the technicians are already going to Kenyatta National Hospital for some refresher trainings. They had already been trained in Egypt and South Africa, but they need some refresher trainings. And then, like I said, there will be teams coming from Indiana University and University of Toronto to assist also with the trainings. So that we will be inviting you in the new year to witness the first surgery being done, the first open heart surgery being done at Moi Teaching and Referral Hospital.
This is our accident and emergency department. It acts as a filter for patients who have different kind of emergencies. It could be accidents, it could be poisoning, it could be people who have been involved in floods, any type of emergency. But it also serves as an area for ambulatory patients, because we don't have an outpatient for ambulatory patients. So this room where we are is the emergency room. This is where we see the critical patients. And then we have a room called room 5, which acts as a ward for admissions, for temporary admissions for patients who are emergencies for a period of about 24 hours. And then we have room 14, where the walking patients, the ones we call ambulatory, are taken, and there's a nurse there who triages them. He sorts the patients out. We also, at the entrance of our accident and emergency department, we have also a desk where a nurse sits and triages patients according to their illness. Those who are very sick come to this room, which is room 4, the emergency room. The ones who are walking go to room 14. The psychiatric patients, because we realize that psychiatry is a special kind of disease in its own. And most of the time, patients are accompanied by many people. And they kind of cause disorder if they are mixed with the other patients. They are seen in room 5. And also students, we give students a special kind of filter. So they are also seen in room 5. So our accident and emergency department also has an X-ray department. It has a records department where patients' records are taken before they are seen by the clinicians. We also have a department of social work. And the department of social work, their function is to assist those who are unable to pay, or those whose relatives are not available and they have been brought in as an emergency, so that they can receive treatment. By the time the patients, the relatives come, then we do what we call crediting. And then we have the security who help us in taking care of rowdy people who may come in with their relatives, or sometimes we also get some visitors in the hospital who are thieves. So the security are there also to assist us. Then we also have a minor theater, a small room where small surgeries are done. We also have an injection room, and the injection room serves as a place where patients who are getting admitted get their first injections, or they get their first doses of drugs before they are taken to the wards. We also have a small holding room for those who come in dead, because sometimes we receive patients here. When we receive, we find they're already dead. So they come in as dead. So we have a room where we receive them as we await for the mortuary to take the bodies so that they're taken to the mortuary. We have a small store also within the accident and emergency department for the supplies we use in accident and emergency. We have a purpose laboratory which works for 24 hours. So that any patient who comes in accident and emergency is able to be done any type of investigation in our laboratory. It does grouping and cross-match for those who need blood. It does hemograms for those who need their hemoglobin to be known, and small other tests. We also have the billing department is also within the accident and emergency. And we have a place we call phlebotomy room where specimens are taken from. And as I told you, we also have the X-ray department. So once the patient has been seen by the clinician, is wheeled by the nurses to the X-ray department, where the respective X-rays are done, and then they are brought back to the clinician to interpret what is going on with the patient. The average number of patients who are seen on daily basis is about 300 patients, both the accident and emergency patients and the ambulatory patients, the walking patients. But the majority are the walking patients. We have plans to expand this region, the accident and emergency department, so that we have a purposely built outpatient department, so that we don't have accident and emergency patients mixing with walking-in patients. And the catchment area for the hospital is the western region, and the western region extends up to Nyanza, up to Uganda, Rwanda, Congo, and we have a North Rift region. We have about 15 million people, so that's our catchment area for this region. And every patient passes here, and this is the sorting area. We have about the number of clinicians who work in accident and emergency is about 47. And this is the only hospital where we have 24-hour service. There is always a clinician. The clinician is not on call, he's on duty. So when the patient comes, the clinician is in the room to see the patient. Other hospitals have what you call people on call. So once the patient arrives, the doctor is called from wherever he is. But in our accident and emergency, we have clinicians on duty every day. And on daily basis, they are divided into 2 rotas. 3. There's the morning, the afternoon, and the night duties. And at any one time, in room 4, we have 3 clinicians, and then we have other rooms also where we have clinicians. We have room 16 and room 17. And those rooms also have about 4 clinicians. So in total, at any one time, we have about 8 clinicians to see patients. And most of the time, the patient load is more on Mondays, Tuesdays, and Fridays. So sometimes a patient can come who is not very sick, and there are those who are very sick. We give priority to those who are very sick. And those who are not very sick may start complaining that they came along and have not been seen. But it's because they are walking patients. And our priority is to the patient who are very sick. In MTRH, we boast as the only center where we have specialties in all the areas. All the specialists are found in this hospital. Apart from Kenyatta Hospital, it's only MTRH who has the highest number of specialists. We have a big reserve of specialists, whether it is orthopedics, whether it's neurosurgeons, whether it's gynecologists, whether it is pediatricians, whether it is neonatologists. All of them are here. All the neighboring private hospitals depend on specialists from Moi Teaching and Referral Hospital. Without this hospital, those neighboring hospitals will not function because they depend on specialists from Moi Teaching and Referral Hospital.
We do serve mostly adults. These are patients who are 14 years and above of age. We see various conditions, but most conditions that we see are trauma. We receive a lot of patients with limb injuries, patients with head injuries, patients with chest injuries. We do also receive other critical cases, either from home or as referrals from county hospitals and also from neighboring private hospitals. We do strive to ensure that all patients who require emergency surgeries get the surgeries done within 24 hours. That's one of the hallmarks of this department. And we do ensure that no patient goes to the wards before they go to theater to get the emergency surgeries done. We do also have what we call service charters. The purpose of this service charters is to inform clients on the process and the services that we offer them and the durations that will take for these services to be done. This has helped a lot in reducing delays. We also have 24-hour customer care service, so that if any client has a concern in terms of compliments or complaints, there's an officer to address all those complaints at any given time. We do also have a laboratory that is specific to requirements of the emergency department, and this laboratory is able to carry out all the basic investigations that are required for patients who have come to get emergency care. Also in our unit we have what we call immunology lab. It is peculiar in the sense that it is able to run a lot of assays that are not run by other facilities in the region, and it has been placed specifically and strategically at the outpatient setting, also to serve other clients who may come specifically for those tests. We are talking about tests like, prostate-specific antigens and various tests that usually guide tumors, guide the diagnosis of tumors. We do also have various departments within the unit. We do have records, we do have billing, we have social, we have radiology. So it is like a one-stop area, a one-stop service unit where all the services can be obtained without having clients moving from one area to another. We also have dedicated clinicians who work 24 hours. They are permanently in the unit. So whenever a client comes, they will get a clinician to attend to them immediately. We have a pharmacy that contains almost all the essential drugs in the hospital. So we don't have a situation in which clients have to be sent elsewhere or have to be asked to obtain drugs from other places. We do also have a new radiology unit. This new radiology unit has improved the quality of the X-rays and the speed and the time that it takes for us to get these X-rays. We do also over 24-hour services like MRI and CT scan. These are specialized services that are not found in any other public hospital in this part of the region, particularly the MRI. We are able to do MRIs of the brain, MRIs of the small parts like the neck, the spine, and the joints. We are going to improve on it so that we can also do MRI of parts of the body like thoracic cavities and abdominal cavities. We do also have a triage system. The purpose of this triage system is to help us in sorting clients and categorizing them accordingly, according to their condition. This is to avoid a situation in which very sick patients will be left out. We do have also a triage system for mass casualty patients. Therefore, whenever we get a mass casualty incident, usually we are very organized, and it is because of that quality work procedure manual that states the roles of each and every person in the unit that we are able to manage mass casualty incidences very well whenever they arise.
Here in accident and emergency, what we do is to make sure that our clients get the best services that MTRH offers. We give directions to all clients that pass through here. We give guidance to all clients that come here and they don't know where to go or what to do. We are trying to make sure that this department, people come here to get the services that they are intended to have. Currently, we are making sure that there are no congestion in this place by making sure that all people that come here are patients, and the relatives have to wait for their patients outside while all services are done, except those patients that come here and they are not able to speak, or they are not able to move. That's where we allow at least one person to come and assist.
Emergency lab is part of accident and emergency department, and in this particular laboratory we receive samples from patients with critical conditions from the emergency room, and also we serve walking in patients who come in for medical attention. As an emergency laboratory, we offer routine services that includes analysis of blood for common tests, common investigations like typhoid fever, brucellosis, malaria, and other common diseases that affect the people in this region. Apart from the kind of services that we offer, we also receive various human samples, including blood, stool, urine, and other body fluids for purposes of testing for disease. As an emergency lab, we are fully equipped to offer such services. Some of the machines that you see in this laboratory are the latest sophisticated equipment that we use to provide these services. This is a 24-hour service provider. We have our duties split into 3. We have those who come for morning shift, those who are coming for afternoon shift, and those people who come for night shift. So we work 24/7. There are some services, of course, which we don't provide in this laboratory, but our sister labs within the hospital will offer those services. Like on the other side, we have a fully fledged biochemistry laboratory, a fully fledged hematology laboratory, microbiology laboratory, histopathology laboratory, and immunology. These ones offer more complex services that are not even offered in other hospitals within the region. And therefore, we offer most of the services, even those ones that are referred from other institutions. We have patients who come from the entire part of the North Rift and parts of Western Kenya, and even beyond the borders, who come purposely here for laboratory investigations. We are an ISO-certified institution, and as part of the hospital, our services are up to international standards, and at the moment, we are also working towards accreditation of our labs. That is, we are out to obtain a standard that we call ISO 15189, which is purposely targeted to ensuring that our medical laboratory services in this hospital are at par with international hospitals. Our personnel also are trained. We have people who have right from diploma to master's level. And therefore, you can be sure that if you come to our laboratories, you will get standardized services. The services are offered in the county hospitals. Of course, when they come here, we perform a higher and superior services.
Here we triage them by taking them vital signs, that is the blood pressure, temperature, before they are registered and then taken to the clinician. So the rule of triage applies here, in that there are those patients, when they present to our unit, their condition deteriorates, so we triage them as fast as possible so that they can be seen by the clinician. So that is basically what we do here, in that patients come in, we take their vital signs. If they are vital signs are deranged, we take appropriate action. So then the person manning the triage point is the nurse, and then their records clerk who will register the patient after they've presented with the registration number. Then they go make the payment. After payment has been made, a file is generated, and then the patient is triaged to the clinician. Both we get self-referrals and referral from other facilities who come to this place for quality health care, which we offer. So it is a very busy room in that we see clients from all over. As far as Turkana, they come in here with their referral letters.
Center for Assault Recovery Eldoret, abbreviated as CARE, is MTRH's gender-based recovery center. It is based in Accident and Emergency Department in room 6. In the center, we see survivors of gender-based violence and sexual violence. Gender-based violence, specifically domestic violence cases. At the center, we offer medical management of the patients as well as counseling services. Moreover, we offer legal support through P3 filing and further follow-up in court as expert witnesses. The center has been in service from 2007 following the post-election violence and has seen an increase in the number of cases, and we continue to offer quality care for these patients. A care center serves the greater Uasin County and part of Western Kenya, and offers these services to the patients. We also do outreach services to schools to sensitize the students as well as the teachers on sexual violence. We also do support groups, monthly support groups to our survivors, in addition to the individual counseling that is offered to patients in the center.
This is where you receive our casualty patient. Whether it's accident, referral from periphery hospitals, they call us, they inform us the condition of a patient, then we receive here. Those who are not able to walk, we receive with stretchers or wheelchair. Then we prioritize their patient by triaging. For emergency patient, we refer them to emergency room. For patients who are walking, we refer them to ambulatory section. And it's nobody who is denied services, even if they don't have money. If they don't have money, we refer them to number 2, just next to us, for social work to see the patient. For emergency, they just go direct. Then the number 1, they pay for the services. Then go for registration. We have X-ray department within our department. And also for CT scan, we refer them to CT scan. We are unique that because we are only referral hospital with North Rift, and the care we give is quality. And whether they have money or not, we are able to sort them out. From emergency ward, we see students with the uniform so that we can give them time to go back to school. And also we see all our psychiatric patients in emergency ward. Then we admit them or we discharge them on treatment and for follow-up clinic.
Reproductive health as a division has several sections. We have Riley and Mother Baby Hospital, which has a labor ward, antenatal ward. We have the postnatal ward, mothers' hostels, and we also house the neonatal birth unit, that is NBU, which is under the Division of Pediatrics. So still under reproductive health, we have the gynecology ward, which is known as Faraja ward. And then we have the reproductive health and well baby clinics, which is a standalone department in the Division of Reproductive Health. So if I may start with the reproductive health and well baby clinic, it is set up in such a manner that it has different sections. It has the antenatal clinic, which manages mothers who are undergoing normal pregnancy. In this case, they have no complications. But once a mother is identified to be having a complicated pregnancy, they are sent to a high-risk clinic. And in this clinic, the frequency of the visits is increased. It's not like a mother who is having a normal pregnancy, so they'll attend clinic more frequently, such that we'll be able to monitor the pregnancy. If there's any complication, they're attended to as is appropriate. Then still under reproductive health and well baby clinic, we have other clinics. Once a mother is discharged from the postnatal ward in mother baby, they'll be given a return date after 2 weeks, at which they'll come for the postnatal clinic. Then we have also the gynecology outpatient clinic, where the gynae patients are booked, then they are seen. If there's a need to admit, then they're admitted to gynecology ward, which is Faraja ward. Still under reproductive health and well baby, we have the well baby clinic. Initially, we used to see mothers and babies who are well, including those who are unwell. But right now, we have moved a phase up. So we have integrated the management of mothers and babies who are exposed. That is mothers who test positive during their pregnancy, or maybe their serostatus is already known, so they have been on treatment. Initially, they were seen in AMPATH, in one of the modules in AMPATH, but right now the whole care is integrated. So all the mothers and their babies are seen in the same clinic as those for the well babies. So in such a manner, we have actually reduced on the aspect of stigma for the mothers and the babies. So all the services are integrated, so it's a one-stop shop in terms of care for the mothers and the babies. Now coming to gynae ward. Gynae ward, that is Faraja ward, they admit gynecology patients, that is of course female patients, and they also admit patients who have had incomplete abortions. And in this, we do day cases for MVAs, that is, we manage these patients by doing manual vacuum aspiration for the patients. So that is also an aspect which is there in the gynecology ward. And coming to Riley Mother and Baby Hospital now, which houses the 3 wards, we have a labor ward. Since the institution of free maternity services, we've had an upsurge of mothers who are admitted here. So you realize that per month we are serving more than close to 1,200 mothers who deliver here, 1,200 mothers as compared to before. So actually it has been a plus for maternal and neonatal health care, because right now we are having very many mothers, more than 90% of the mothers delivering in a health facility. So per day in labor ward we'll have close to 40 deliveries. Labor ward, we've had improvements. Right now we have a triage unit, which was not there before, so it's an innovation that has been done. Such that the mothers, once they come in, they have a lounge where they're able to sit comfortably as they await to be reviewed. So the most critical cases, meaning the mothers who are high risk, maybe they have complications, will be first identified and they're taken to an emergency room where they are attended to. So you'll have some of the other mothers still waiting to be seen as the emergencies are attended to first, given that priority. But at least we have a system where we're able to triage and filter, so that we're able to identify that these are priority mother and these are mother who can wait a bit. So that's an innovation that has been there in the labor ward. We have 6 cubicles, which are very comfortable. We have 3 delivery coaches per room, so our mothers are quite comfortable to deliver. They don't share beds in labor ward. So each mother has a coach, and there's 1 midwife, and we have consultants and registrars who cover the floors 24 hours. So you'll have from an MO intern up to the senior most, who is a consultant covering the labor ward and the theaters. So coverage in terms of healthcare providers is adequate. We have the antenatal ward, which also has a bed capacity of 40. So at one point in time, averagely we have 35 to 45 mothers in antenatal ward per day. So also we try as much as possible to ensure that the mothers are comfortable. So once a mother is admitted to antenatal ward, they'll be monitored, and once they're ready to deliver, they'll be taken to labor ward, they'll deliver, and lastly they'll land in postnatal ward. So we have postnatal ward on the first floor, which houses the mothers who have been operated on, they delivered by C-section, and then we have the mothers on the second floor. Those are the mothers who just delivered normally. So most of the time we'll discharge them after a period of 1 day. If they have any complications, they'll stay longer. But on average 1 day, and a mother's already left home for the baby. And of course we have the nursery, which is closer to our theater, such that once a baby is delivered by C-section and they need to be observed, the nursery is close enough. So it's also situated next to the labor ward for close proximity. In terms of once a baby is delivered, immediately they can go to NBU.
Here in diagnostic, in Department of Radiology, we have a wide range of services ranging from X-rays, CT scan, MRI, mammography, and ultrasound services. On top of that, we also do interventional procedures, including diagnostic biopsies, CT guided, ultrasound guided, and therapeutic procedures like drainages of abscesses, ascitic taps, and installation of treatment into tumors. Now, MTRH as an institution is one of the leading centers in the country in provision of radiological services. I think apart from Kenyatta, this is the second largest public institution in terms of service delivery, and this includes radiological services. The equipment that the hospital has managed to acquire is modern and among the best in the country. We are able to do virtually all examinations, be it MRI related, CT scan, ultrasound, and X-rays, radiography. The staff that we have are highly trained, specialized, and we continue to give them opportunities to develop skill and remain competitive in the market. The MRI that we have is capable of doing virtually every test, ranging from brain examinations to diagnose tumors, injuries, bleeds in the brain, and other conditions. We are also able to evaluate the extremities, the joints, do knee examinations, shoulder examinations, elbow examinations, orango examinations. About the spine, MRI is invaluable in evaluating the spine. People complaining of lower backaches and all that, MRI comes in handy. The MRI is complemented by the CT scan, which also offers a wide range of examinations, including brain scans, abdominal scans, extremity scans, and even the spine. For ultrasound, we do virtually all examinations, abdominal scans, pregnancy-related examinations, gynecological examinations, or evaluation of systems like the kidneys, hepatobiliary, and urinary system. We are able to do here. For interventional work, is a new concept that is being developed. We are able to do diagnostic biopsies. Diagnostic biopsies is a process of removing a tissue from pathological growth for histological examination, and we are virtually able to do all biopsies aided by the equipment that we have, CT scan and ultrasound. Therapeutic aspects, if there is a pus collection, we can avert surgery by draining or aspirating the abscess dry, and then the patient would continue with medication, and then evading the necessity of surgery. People with fluid accumulation, ascites, with distended abdomens, we are able to do drainage with the ultrasound guided. We are able to do nephrostomies for people with obstructed kidneys, perhaps with a tumor of the bladder or the cervix. So we can relieve the obstruction by inserting, doing nephrostomies using ultrasound guidance or CT. The X-ray machines that we have are the modern. We've moved from the analog to digital. We are able to give our images and reports in electronic form. We can also disseminate to wherever part of the world. We can send to our friends abroad. Like now, we collaborating with Indiana. We are able to digitize the information by virtue of the machines being modern and digital. In process, we will do away with the analog form of examination where we have to print hard copies of X-rays. Soon we'll not be seeing the blue envelopes that people carry around, because the information will be in electronic form. The X-ray machines, the modern X-ray machines that we have two big ones that are able to do in excess of 100 cases in a day per one machine without giving any problem. The same to mammography. We have the latest digital mammography machine that we are able to carry out screening tests on the breasts and diagnoses and even biopsies of the same, and do follow-ups for those who have been done surgeries. For ultrasounds, we have also among the best ultrasound machines, and we are capable of doing on average about 70-80 patients in a day, and they give us excellent results. The staff the department is well staffed with well-trained staff, radiologists and radiographers, and the support staff, so that we are able virtually to offer any radiological examination as requested. In the recent times, we've not had any referral of any case that needs a radiological examination. One other examination that I had not mentioned is angiographies. The evaluation of blood vessels when there is a blockage or a rupture in conditions like aneurysms. We are able to do both CT angiograms and MRI angiograms to facilitate the treatment.
In MCH, we have different sections, whereby we have the well baby clinic. Here we take care of the well babies who have come for immunizations. We see them from 6 weeks up to 2 years, and they are given immunizations from the time we come in contact with them until they are 18 months old. Then also we have a section whereby we take care of HIV exposed babies, HIV exposed infants, whereby it is an integration from empathy department. We usually take care of these babies by checking on their welfare, giving them treatment, and also giving them appointment visits and giving them counseling. So we do it in a deeper way, in that we counsel these mothers and they get, we usually stress on adherence to treatment. And as our patients come to the MCH clinic, we have the triage department, whereby all mothers come to us and we do vital signs of temperature, pulse, respirations, and blood pressures. And in case of any problem that is alarming, maybe a mother has a high blood pressure in pregnancy, we refer these mothers. We take these mothers as emergency, and we take them to the expertise, to the experts to take care of them. That is the consultants and the clinical officers who are taking charge in the clinic. Then these other mothers is a routine. They come for routine checkup. We do their vital signs in triage, and then we give them direction accordingly. From here at the triage, they go to room 32, whereby they are supposed to do the payments, and they are also guided to the rooms that they are supposed to be seen. We have different categories of mothers that we see here. We have those mothers who are normal, who are carrying normal pregnancies with no complications, and we have mothers who have got complications. Like these are the ones we call the high-risk mothers. So from room 32, they're directed to which room they should go. We also take care of the family planning clients who come and are seen in room number 29. We also do voluntary prevention of mother-to-child infection, where PMCTC, whereby they are all, the mothers who come, especially for the first time, are tested for HIV, and together with their partners. We also have a laboratory in this department, whereby all mothers who are pregnant go to the laboratory, are done for antenatal profile, which includes the hemoglobin levels of the mother and other parameters of the blood works. So basically that is what we do here, and we work in harmony, and the flow is okay.
The private wing is composed of many units. It's a fully fledged hospital with all the usual hospital units. We have maternity, we have a fully fledged OPD, we have diagnostic services, we have specialized clinics run by consultants, and one of our real strong points is that we have consultants who run the clinics, and all clinics are available in this facility. The OPD complex, which was just opened in June last year, is an ultra-modern unit with all facilities that we require. We have dental units, we have the specialized clinics, We have reception area, resuscitation area. We run mother-child services. We run. We are having also an X-ray unit, and also in future we're going to have an MRI unit within this unit. The other areas in that we have in this facility is that we also have wards. The wards are, we have about 54 beds. The 54 beds comprise general wards. We have semi-private wards, and we have highly private wards, where our clients can enjoy the comfort of being sitting in a hotel-like facility with a very conducive environment, the flowers that we have, the gardens that we have, makes it a home-like for quick recovery for our clients. We also have an ultra-modern theater where we do all kinds of operations. We have all the machines to do all the operations that are required in any facility, in any hospital. And with the association with the other parts of our hospital, we do have diagnostic services like MRI, CT scan. We do have ultrasound machines, X-ray machines, which enables us to have the best for our clients. We are also a NISO certified facility, and therefore our care is to the best care that we can afford and also available in the world, as we have a standardization system where we follow our ISO certification and we look at the quality of care. The other thing that we do have is that we are privileged to have a lot of committed staff. Our staff are highly committed to the work that they are doing. They are highly trained, they are customer friendly, they are very loving people. They usually have a feeling of ownership of the facility. And therefore, if you come here to our facility, I'm sure you'll have quick recovery. You will feel more at home than being in a hospital facility. We are committed to giving affordable quality care. Our prices are very friendly. We give the best quality but at the lowest price. Since we are a semi-government facility, we give a subsidized services where our prices compared to our competitors is much lower, and also of high quality, the best quality that you can get within the region. Our staff are very committed. They are very loving people, as I've said before. And the other thing that we have as a quality, as an advantage for us is that we are also very close to town. It's a walking distance. If you come for our services, sometimes you don't have to take a vehicle, you don't have to take a cab. You can walk in once you are light in town very comfortably. And if you want to use any kind of vehicle means, we are very close to the town. Therefore, taxis and matatus are available. You don't have to struggle to get to the place. The other advantage that we have is that with the closeness of being in town and closeness of being in the central business district, we have the other advantage of we can easily refer you if you need other services that we don't have here and we could find within the locality, within our neighboring facilities. We are almost at the center. Whether you're going to the east or the west, we are fairly at the center. Anything that you require, you will get.
What we normally do here, we give direction to the patient all over the hospital. We handle complaints that come in before the main office that we can handle before the main office. We sort out each patient or any visitor who is coming before the management. Yeah, so that is mostly what we do here. And we welcome any visitor who comes first before we take them to our main office.
In consultants clinic, we carry out special clinics. In this consultants clinic, we have several clinics. We have the surgical clinics, we have medical clinics, we have the pediatric clinics, we have the fracture. It runs from Monday to Friday, and the flow starts from the triage, and then the patients are directed into various rooms by the nurses in charge of the rooms. In total, we have room 47, 48, 49, 50, 51, 52, 53, up to room 62. In room 62, that is where our nutritionists counsel our clients. And after that, they go to room 42 to book their clinics. In Moi Teaching and Referral, we value our clients, and we serve our clients according to first come, first serve. It's only in serious occasion that we give our clients first priority when they are very sick or they require higher services than what we give here. That is when we give them priority. Otherwise, we serve them according to first come, first serve. Our clinics runs from 8 a.m. to 1 p.m.
Welcome to Moi Teaching and Referral Hospital Training Center. This is a center of excellence in health education, and we specialize in training higher diploma programs, basic diploma programs, and also certificate programs in health-related programs, in health-related fields. At the training center, it's headed by a principal and 2 deputies. The following are programs which we offer at the training center. And I will start with the higher diploma programs. That is higher diploma programs in nursing. We have critical care nursing, that is ICU nursing. We also have renal nursing, and we also have oncology nursing. This is a new program which will start in September 2016. We also have higher diploma programs in clinical medicine and surgery, including the following. One is higher diploma in mental health and psychiatry for clinical officers. We also have higher diploma in medical oncology for for clinical officers. We also have higher diploma in pediatrics and child health, that is for clinical officers. Now, the other programs which we offer include diploma, basic diploma programs in Kenya registered nursing. We also have basic diploma in orthopedic trauma technology. We also have basic diploma in health records and information technology. Those are programs which we do for 3 years, and they start every year September, or every September of every year. Now, we also have certificate programs at the training center that include certificate in health records and information technology. We also have a certificate program which is in mortuary or mortician services, and we also have a certificate program in anesthetic assistant. These are new programs which are offered at the training center, and they are not anywhere else in Kenya. We also have certificate program in or proficiency course in life support, BLS, which we offer at the training center. That one is offered as per demand, and it can be offered every week or after every 2 weeks, and that one takes only 3 days to study. At the training center, we are also happy to introduce the first in-service program in orthopedic trauma technology in September 2016. And we want to invite all the applicants to come and apply for all these programs. Visit our website www.mtrh.or.ke to get a downloadable application form, fill and follow the instructions, and submit at our MTRH Training Center registry, and you will be given a chance to study with us. The number of students currently is 674, although with the new programs in oncology nursing and the program of mortician services, we expect the number to rise to 750 in this academic year. And therefore, the training center is actually growing at a very fast rate. Staff complement, our staff are highly qualified, drawn from all fields. We have highly qualified nurses who train, highly qualified doctors, clinical officers, records, and also other support staff at the hospital offer trainings at MTRH Training Center. Most of them have degrees or masters or higher diploma in their qualifications. Future plans, the training center is going to expand, and we will expect to grow and build up a complex whereby we will offer specialized trainings in all health-related fields. We want to go specialization in terms of higher diplomas, certificates, and any other qualifications. And most importantly, we want to do research in healthcare.
This is the chemo administration area. It is the place where anti-cancer drugs are given, and as you can see, we have made it very comfortable. We have recliners there because administration of these drugs takes a little longer, and most of the patients with cancer will require chemotherapy either before or after surgery, or in some cases it's just chemotherapy alone. Yeah, and this is where we give them. It's very spacious. Patients sometimes have to come here every 2 weeks, up to 12 times or even more, and sometimes even up to 5 years as we continue with maintenance treatment for the cancer. Yeah, so that is why these people are here. We give chemotherapy every day from 8 to 5. Yeah, everybody requiring chemotherapy gets it here every day.
From Ampath mostly, and some are coming just from referrals, self-referrals. Yeah, and we see those mothers who are at the age of reproductive health from 18 to around 50 years. Yeah, and we do our screening using VIA, that is visual inspection with acetic acid. You can see some abnormal cervix here. These are normal cervix. When we do our VIA, if you find it is normal, that's how the normal VIA looks like, and that's how abnormal VIA looks like. Yeah, and we also do treatment using cryotherapy, basing on the lesions that we normally get. And we also do something called colposcopy. Normally we screen from Monday to Thursday, then on Friday we do our treatments. Yeah, and we also, when we get suspicious cases, those ones who are having cancer, we normally refer them to oncology for treatment.
We have a total of 4 ENT surgeons in the Moi Teaching and Referral Hospital. And we have an established ENT unit, which consists of various sections. There is the ENT clinic, which offers outpatient services on a daily basis. Then there's an audiology unit which does hearing and hearing disorder screening and management. We have surgical wards where we admit our surgical patients, both pre-operatively and post-operatively. We have a theater. We have about several theater days a week, 2 or 3, for elective cases, and we have emergency surgery on a daily basis as they come. We do also endoscopic procedures in the department and also in theater. We have various projects, ENT projects in a year. We have the head and neck cancer screening project every May. Then we have head and neck surgery camps every February, which lasts for about 2 weeks. We also have eardrop surgeries of the ear, Operation Eardrop projects twice a year. That is in April and in November every year. In addition, we also have outreach projects where we go out to the nearby facilities and give our services to the people on the ground, especially those who cannot get to MTRH because of maybe communication problems, transport, and or financial problems.
In dental, we have different services which are offered in dental, in MTRH. And the services we offer here are as follows. We have an area which is dealing with the extraction of teeth, and that is called the exodontia area. And here, mainly the clinical oral health officers and the dental officers, they deal with the extraction where the injections is given to the patient in order to cause numbness so that the patient cannot feel pain during extraction, and that is part of our services offered to manage pain before the procedure is done. So once the patient is injected, the patient stays for some few minutes and then the extraction is done without pain. And before that, once the patient enters in dental, the patient is received by the nursing officer, and the patient is directed to the records area where the retrieval of file is done and registration. From there they go to the pay point. We have a cash point where there is a staff who deals with the payments of the services offered in dental, and the services offered are within patients' comfortability, and they are at least within the low rate. Then from there the patient is directed to the triage area where a nurse receives that patient and triaging is done. In the triage, the nurse mainly takes the vital signs of the patient to rule out other minor ailments or major ailments of the patient, and the filter is done in the diagnosis clinic where the clinicians are usually present there, and it is the area of filtration where patients are directed to the different types of services. And in those services, we have also, apart from dental extraction, we have an area where it is called conservative area. In this area, there is a clinician in that room who does the restoration of teeth for the patient, because mainly we advocate for the restoration of teeth more than the extraction. And there, the filling, root canal treatment is done, and the patient undergoes different sessions before it is complete. We have another area where it is an area of surgery. In surgery area, we have the clinicians there, where the surgery is done by the clinician. Mainly we do biopsy, and also when a patient comes with the cut wound, there is stitching done in that area, and also dressing is done in that area, mainly for the outpatients as well as for the inpatients. They come for dressing in that area. And we have an area of dental lab. In the dental lab, we have dental technologists, where there is, it is called prosthodontic area, where they repair the teeth, they make the partial dentures for the clients. Those are our customers in MTRH. And also they replace teeth, can be done by the dental technologists in conjunction with the dental officers. And in the same area, we have different part. There is that part of taking impression, which is done by the dental technologist, and there's another area where it is the fabrication area, where everything is done in that area. And in this dental, we have another branch of dental department in Memorial. It is a branch from this area that is in private wing 2, where the clinicians are there and all the services are offered the same like in this other, in the MTRH. And in our department, we work in different sections. We have also the nursing section. And in the nursing section, the services offered, they maintain the sterility during all the procedures done in the department. The nursing officers, they are well conversant with the autoclaving issues, whereby all the instruments used are autoclaved and are free from germs before the clinicians use them to the patient. So in the nursing, we have the process of decontamination. That is, when a clinician finishes with the procedure and the instruments used are soiled, there is an area where it is called the decontamination area. They have the decontaminant in it. So every clinician is aware, and they just immerse the instruments used in that decontaminant, and then it is removed from the decontaminant after 10 minutes. They are cleaned in the soapy water, rinsed in running water. We have taps which have water which is running, and then from there they are taken to the sterilization room, where it is dried, ready for repacking, and then to be autoclaved again, ready for use, and the cycle begins again. And in the area, we have also the patient attendants, who at least are well conversant with the decontamination, and they do also the cleaning of the linen in our department. Then they are dried, and then after that they are folded to be autoclaved in our area. We also have the supportive staff, the stewardship, who do the cleaning. They maintain cleanliness of the department, and we work hand in hand with them. We also have the security department, whereby they keep watch of the area for the safety. We have the PROs department representative, who at least deals with the matters which the patients want to know. And we also have secretary, who also deals with the office work, and especially the letters, referral letters, she helps in typing them, filing. All this is found in dental department. Also, we make sure that we educate the community within our catchment, and mainly once they come here, they are given the health education on oral hygiene. Apart from being in MTRH, we also extend our services to the community outside. We educate the patient and make the community aware of the oral hygiene and how to maintain their oral hygiene. And in case of any further treatment, mainly what is done during outreach is dental extraction. The extraction of teeth is done especially for those who are beyond repair. And the ones who are able to be repaired, they are at least referred to the MTRH dental department, and then we make follow-up for the patients. From there, we make several outreaches in conjunction with the community and the management, especially the PRO's office. We communicate, and then we go for a multi-outreach services outside.
Our kidney unit, renal unit, started in the year 2002. We started off with peritoneal dialysis, where we remove fluid. We remove wastes through the peritoneum in the abdomen. Within 6 months, we had graduated into doing hemodialysis, that is removing wastes from the blood using a machine, dialysis machine, as people popularly know it. Then, within 4 years, that is in the year 2006, we carried out the first 2 kidney transplants in the hospital. They are both alive and well. And we partnered at that time with Indiana University, and the famous surgeon called Mark Peskovitz unfortunately passed on about 3-4 years ago in a road traffic accident in Indiana. We have progressed and continued to do kidney transplants. By the time Mark died, we had done 8 with him. After his death, we partnered with a doctor-to-doctor program from Holland, Netherlands, Amsterdam, and we have been able to do 16 kidney transplants with them. So in total, we have done 24 kidney transplants in this hospital. Our success rate has been very high. So far, we have only lost 2 patients, really on us. One died from malignancy, cancer, which is due to problems with, which was due to the problems with the drugs. The other one had a heart problem and passed on. And of course, I was forgetting the recent one, so we have lost 3. The recent one passed on because of complications which were not discovered during the investigations. He had multiple medical problems, the liver, but investigation revealed that the liver was okay. So it is only after the stress of surgery that the liver failed, and there's so many complications I don't need to get into. Otherwise, he died with a functioning kidney. He died almost 3 weeks after kidney transplant. But his function, the kidney was not the problem that killed him. The kidney was okay. So we can say that he died from the complications of the liver problem. And then the department has continued to grow. Right now, as we speak, we can dialyze up to 10 patients at any particular moment. But we are opening up a big center in the chronic disease center in the hospital. We are going to be able to dialyze up to 20 patients simultaneously. The work for partitioning of the place is starting was starting this month, anytime. The contract has been awarded, etc., etc. Now, the other side where we are growing is pediatric nephrology. We now have a pediatric nephrologist around. We are first graduated from South Africa, and we are starting a parallel service, kidney service for children, and we hope in the not far distant future we'll be able to do kidney transplant in children. The challenges we are facing right now is in developing the department is personnel. We have trained nurses, trained nephrologists. In fact, we have one coming from South Africa very soon. We had sent them out for training. And we have 2 trained surgeons who have been helping in doing kidney transplantation. But because we don't do regular kidney transplant, they are not very well exposed. We are looking for a place for them to be attached there, even if it is 3 months, where they carry out those operations on a daily basis, so that, surgery is a skill. It requires that you do it daily, so that you perfect the art. So that is what we are looking for. We are also trying to recruit young people to join the Department of Surgery, so that they can, Department of Surgery, and from there they come to kidney transplant program. This is a big problem in the hospital, as I said before. We are having 20 to 24 people joining the dialysis program in our hospital per month, meaning those are people whose kidneys are knocked off, and those are almost, in fact I would say almost all of them are transplantable. So you can see how kidney transplant is going, is really the in thing now. Dialysis is very expensive, and before we even realize, you will see the government change its policy, because I know it's going to change. Sudan started like that. The government ordered for dialysis, free dialysis for everybody in the country. It didn't take long before they realized that they couldn't afford it. So the government changed the tune and offered free kidney transplantation for the people. So they realized the kidney transplantation is very cheap. It is the initial input that is high. Like here in the hospital, we transplanted 600,000 shillings. And as opposed to India, which is now, many centers are putting 2 million. Other centers, they used to be 1.5 million. If you go to private sectors in this country, some put 1.5 million to 2 million. One of the causes of kidney failure now is HIV, AIDS. Now, this comes about because of two reasons. It can either be because of the virus itself destroying the kidney, or because of the drugs we give for HIV, which can also cause kidney failure and may also make it irreversible. So when an HIV victim gets a kidney problem, it can either be reversible or irreversible. Now, that is acute. If it is acute, we reverse it. If it fails to reverse, it becomes chronic, and the end result will be kidney transplantation. We have quite a number attending our dialysis center. Recently, in the last kidney transplantation, for the first time in the country, we carried out a kidney transplant on an HIV-positive recipient who was given a kidney by the sister who is HIV negative. And usually such patients, we used to send them abroad. But we were able, in fact now, having done this one, we are sure we can do many. If we no longer feel challenged with carrying out kidney transplantation on HIV-positive patients.
Our core mandate is to ensure preventive and promotive health care services in MTRH entirely, and of course our environs in partnership with Uasin Gishu County and other counties in this country. In MTRH, we have a lot really in terms of preventive and promotive healthcare services we provide to Kenyans. To highlight a few, we carry out environmental sustainability assignments, which goes a long way towards the realization of Millennium Development Goals of 2030 in terms of environment. This is done in MTRH in terms of proper waste management, proper disposal methods. Of course, we have one incinerator which has met all the requirements in terms of licensing by NEMA. In terms of byproducts, of course, it is safe. And that's why we assist all our environments and other encroaching facilities in terms of disposal services. Secondly, international vaccination services we provide here in MTRH. International vaccination services is a requirement for all international travelers, and that does not really bar other Kenyans who are really in need of the vaccines. Such vaccines include yellow fever, varicella vaccine, meningococcal vaccine, among many others. Based on our IVC services we provide, staffs we've cushioned in terms of ensuring their safety is ensured by providing hepatitis B at a very subsidized price, and of course other of course clients. The hepatitis B vaccine is not based on the nature of the viral infections hepatitis B is, because it is well known hepatitis B is 100 times infectious than HIV, and we felt as an organization that I think it is important and paramount for all healthcare workers are provided at a very subsidized price. In terms of vaccination services, again, we carry out, of course, as a referral entity. We provide attention to all snake bites cases in this country, and of course, knowing MTRH is a catchment area for northern and western region, and of course, I'll not forget about Uganda and southern Sudan. Snake bites incidence has been arising, of course, based on the catchment area. In terms of snake bites, really, not all snakes are poisonous or venomous. A few snakes and very specific areas has been identified as the prone areas of such snakes. Always, all beautiful snakes are the most venomous snakes. We talk of catchment area like Kapenguri, of course, the West Pokot. We talk of Baringo. We talk of the western forest, of course, Kakamega Forest. All these are part of the areas where all these cases we encounter in our everyday routines. We always manage them, and so long as all these clans, from the time of the bite, it should not exceed 8 hours before that client is attended, because normally these venoms travel all along to the heart, and the ramifications are a bit more dire. So it is important that such clients are mobilized, urgently addressed, and brought for attention, because it is the only way is administration of antivenom vaccine. That's how you can ensure life and safety of that client is taken care of. And some other tasks we carry out in public health department in MTRH entirely entails infection prevention and control. Infection prevention and control is one of an important provision, really, that needs to be given all the requirements it deserves. Because one, you can't really take care of a patient and you don't take care of yourself as a service provider. And any lapse in terms of both parties, of course, the clients and the service provider, of safeguarding themselves in that environment, the likeliness of prolonging the stay of that patient at the hospital from our anticipated between 5 to 6 days can prolong to more than 6 days or 10 days. Because that one will impact on the financial constraint of the patient, and of course on the clients related to the patient and the hospital entirely in terms of waiving. So our mandate is really to ensure all these provisions in terms of wearing of PPE gears of the service providers, ensuring fumigation tasks is carried out in all prone areas, of course, and ensuring the hospital facility in terms of sanity is ensured at all times, because hospital environments is well known to be prone of hospital-acquired infections. So the continuity of service provisions should be always be advocated for, and it is supposed to be carried out across the board. It's not going to be only public health as a department, but public health is supposed now to impart or share all these information to the rest of the stakeholders in terms of ensuring that such provisions are adhered into. But of course, whenever there is any lapse, it is a mandate of public health to enforce the law, because the law is supreme than these other things in between. So at the end of the day, every employee has a mandate to ensure his or her own safety is undertaken. If you go back to the Occupational Health and Safety Act of 2007, where it indicates very clearly that in Section 6, it is the mandate of the management or the employer to ensure the safety environment of the facility where the employees are supposed to be working is ensured safe. Likewise, it is the mandate of the employee to ensure that his safety is important at all times, wherever he or she is on duty. So it is a collective responsibility that we must ensure we achieve, being a referral hospital, and we intend to be an excellent center of excellence, of course, sooner than later.
Building which houses that division, and it's a new building that was inaugurated last year, August, and we call it SHU for Africa Hospital. It's a very unique building in that it's a hospital within a hospital, and it is a hospital specifically dedicated for children. And for our purposes, children are those who are below 14 years of age. So here we are able to see them. We have the sick child clinic, and that is the outpatient clinic for the children who are sick. So when a patient comes, they'll be received at the sick child clinic. Then they will be, we have doctors, we have clinical officers, and we have nurses. And then if the patient needs admission, that is when now the patient will come to the wards. So if I may start with the ground floor, that is where we are. We have the sick child clinic, we have the lab, then we have the emergency area whereby the babies who are very sick are attended to. We also have a minor theater whereby we do procedures like stitching, wound dressing, and others. And then we also have the pharmacy and the cash offices housed there. Apart from that, we also have a playroom, so that as the children are waiting, they can also be playing with some toys, which helps to make their experience at the hospital not so traumatizing. And when we come to first floor, it has got 3 wings. And in wing 1, we have the surgical ward or the pediatric rehema ward. This is the ward whereby we admit the children who are going for surgery or have come back from surgery. And we have a bed capacity of 27 there. but frequently we admit more than that because the number of patients is usually higher. Wing 2 has the oncology cases, and these are the children who have different kinds of cancers and are undergoing chemotherapy or other forms of management. So the oncology wing has got a bed capacity of 20, and again it admits more than that. Wing 3 is supposed to be ICU and HDU for patients who need those services, but it is not fully equipped yet. So currently we are using it as extra space for the cancer patients until we are able to equip it fully. It also has got space for a burns unit for the children with burns. Then second floor has got 2 wards which deal with the medical patients. We have Wing 1, which has got the Upendo ward, and then Wing 3 has got the Tumaini ward. Both wards have medical cases, things like malaria, anemia, malnutrition. Any medical case, you'll find the babies admitted there. The capacity of Upendo is 34, and the capacity of Tumaini is 36. But because our numbers are higher than that, we have an overflow. So these patients who overflow, we admit them partly to Wing 2. We have some 4 cubes in Wing 2, where we admit the higher number of patients. In terms of staffing, we are highly specialized. We have all the required staff. We have got nurses, we have got clinical officers, we have got medical officers, laboratory and pharmaceutical technicians and technologists. We have got the records and the billing clerks. We have got the public relations officers. We have got registrars for each specialty. For example, pediatric, we have got the surgical, the different specialties in surgery like orthopedics, neurosurgeon, cardiothoracic. So they are all available to see our patients here. We also have other allied professionals like the nutritionists, the social workers, physiotherapists, occupational therapists, and also the support staff that we need like the laundry and housekeeping. So we can see that this is a comprehensive facility that has got all the services that our children need. And of course it will become more comprehensive once the ICU and HDU are fully functional.